the prioritization strategies that we're going to talk about today is who should you see first. And it's going to be specific to maternity because remember, in a med-surg setting, you see the unstable patient first, but in a maternity setting, it's a little bit different. Although we are going to talk about seeing the patient who has unexpected findings. But there's another way you can answer that question as well. And then we're going to talk about when you have one patient who has a diagnosis and then symptoms in the answers, which do you pick? And that's where you pick the unexpected findings. And then we're going to talk about when you have one patient who has multiple symptoms in the question and then says, which order should you implement first? Okay, so that's where we're going to go from here. And I am going to teach you a couple facts about maternity that you may find helpful. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, and you asked for more maternity. So I'm going to do some maternity prioritization. We're going to practice the prioritization strategies that I taught you in the prioritization protocol video in the Walk Through the Blue Book series. So we're going to go ahead and do this. Okay, so that's where we're going to go from here. And I am going to teach you a couple facts about maternity that you may find helpful as you're answering maternity questions. But remember, Clinic Reviews does the best review of maternity that I know of, and I know because I have taught the Clinic Review live in person, and I know what an excellent maternity review that it has. There's also lots of maternity in the Blue Book, which we'll cover as we continue our walk through the Blue Book. So question number one, a nurse is prioritizing care for 4 women in labor. Who will the nurse see first? So you're either going to see a patient who's unstable or unexpected findings, or you're going to see the patient who's most likely going to deliver the baby first. So that's what I want to cover here. We're going to see the patient who's going to deliver the baby first, okay? A woman at 9 centimeters dilation who has been laboring for 5 hours and reports increasing rectal pressure. So when the baby's head is close to coming out of the body, the baby's head presses on the rectum and mom feels like she has to have a bowel movement. And so it could have said increasing rectal pressure, or it could have said feels like she needs to have a bowel movement, in which case you would go, uh-oh, that baby's really sitting low. Now you might say, well, 9 centimeters dilation. So what I would say is let's check and make sure they haven't expanded farther than 9 centimeters. Like they may be at 10 now, okay? So B, a woman at 7 centimeters dilation with contractions every 3 minutes who's been laboring for 8 hours. So don't say because she's been laboring longer than A. So B's been laboring longer than A, but she's only 7 centimeters dilated. She is not ready to deliver. C, a woman at 8 centimeters dilation who's breathing rapidly appears anxious and has been laboring for 4 hours. So we probably want to see her because she's feeling anxious. She's feeling anxious, which isn't really unexpected for someone who's 8 centimeters dilated and has been laboring for 4 hours. I'd expect her to maybe feel a little anxious about it. So I'm not too concerned about C. D, a woman at 9 centimeters dilation who's crying in pain and requesting an epidural for pain management. Again, y'all, 9 centimeters dilated. She's probably laboring pretty hard. And she probably will deliver that baby soon. But there's nothing about crying in pain that tells me she's unstable. This is expected. Lots of women cry in pain at the end, towards the end of delivery. So how am I going to pick between A and D? Because D actually seems like they're more demanding of my attention, right? So D is more demanding of my attention, but A actually is closer to delivery. So I'm going to go ahead and pick A because she's the one that's closer to delivery. And B, C, and D, there's nothing about them that's unexpected or unstable that makes me need to see them. So if I have to choose, I'm going to choose A. All right, question 2. 4 women have just arrived to the labor and delivery unit. Who will the nurse see first? All right, so they've all just arrived. So I need to see who I should see first. All right, let's see what we've got. A woman at 4 centimeters dilation with contractions every 8 minutes, reporting moderate pain. Okay, she's not that far along. That doesn't seem like a problem to me. B, a woman at 6 centimeters dilation with bright red vaginal bleeding and no pain. Okay, painless bleeding is a red flag. So let's keep going and see if anybody else raises a red flag. A woman at 8 centimeters dilation experiencing intense back pain with each contraction. All right, that's very uncomfortable, but it's back labor, and back labor is not an emergency. It doesn't make them unstable. It's extremely painful, but it doesn't make them unstable. D, a woman at 9 centimeters dilation, fully effaced, who states she's been laboring for 10 hours and feels fatigued. So I do want to see her, but she's not unstable, y'all. So I'm not saying I don't want to see A, C, and D. I do want to go see A, C, and D because I'm probably going to do something for them, but it's not an emergency. I don't have to see them immediately, and they're not the first people I need to see. B is the only one that's having a complication of labor, which is placenta previa. Okay, painless goes with previa. So painless bleeding goes with placenta previa. So even though she's only 6 centimeters dilated, I would need to see the patient who has unexpected findings. And I had a comment the other day. Somebody said, I don't agree with the answer because I think this other patient needs to be seen first. Y'all, I get that. I absolutely get that. Okay. We all have our opinions, but the NCLEX does not test on our opinions. If the correct answer is based on your opinion, you probably are about ready to get it wrong. Now, in real life, you do whatever you want to. What I'm telling you is on the NCLEX, you need to follow these rules. Otherwise, you're going to be sort of painfully surprised, perhaps, at your outcome. All right, 3, a client who is 5 days postpartum reports to the Women's Health Clinic with complaints of abdominal pain rated 9 out of 10. So 5 days after delivery, she reports to the clinic pain 9 out of 10 and purulent vaginal drainage. So those are both unexpected findings. I don't expect postpartum for her to have pain 9 out of 10. In fact, I expect her to be relatively pain-free. And if anything, she might have pink drainage, vaginal drainage. It may, for some, it may have changed to white, although probably pink, serosa. Rubra is red, serosa is pink. I would expect it to be rubra initially. It's going to eventually move to serosa. So I don't expect purulent. The nurse notes that the fundus is above the umbilicus. All right, that's unexpected. The fundus should be dropping, and it drops each day postpartum. So it sort of starts out on right after delivery. It should start out, as long as it's contracted like it should have, should start out at the umbilicus, and then it drops over time. So it's above the umbilicus. That's a problem. The healthcare provider has given the following orders. Which order will the nurse implement first? All right, so here we have one patient with symptoms. They don't exactly tell us what the problem is. So they didn't give us a diagnosis. They just gave us the symptoms. So pain is a subjective symptom. So remember, it goes objective, then safety, and then subjective, and then psych. Okay, so pain is subjective. They're rating it. Purulent vaginal drainage is objective. Fundus above the umbilicus is objective. So we have 2 things that we are concerned about that are objective. So administer acetaminophen for pain relief. Well, that's for the pain. So, I mean, I'd like to do it, but it's probably not going to be my first priority since I have 2 objective findings. Perform a complete blood count. Well, that would be nice, but it doesn't treat the purulent vaginal drainage and the umbilicus above the the fundus above the umbilicus. Schedule an ultrasound of the abdomen and pelvis. That sounds like a good idea, but it's not treating anything. It's assessing something. And I need to treat the objective problems. Administer IV antibiotics. So IV antibiotics should be treating the purulent vaginal drainage. Purulent vaginal drainage in and of itself is a symptom of infection. Purulence is always a symptom of infection somewhere. So administering the IV antibiotics is what I have to do first because that's treating the objective finding. And actually the fundus above the umbilicus is also a symptom of infection. So the pain, purulent drainage, and fundus above the umbilicus are all symptoms of infection, probably from placental fragments being left in after delivery is probably the reason she has that. You don't have to make that call here, but that's probably the problem. Okay, question 4. A nurse is assessing a client who's 28 weeks gestation. Which of the following assessment findings should the nurse report to the healthcare provider? So we always report unexpected findings, okay? All right, 28 weeks gestation. So they are in just the beginning of their 3rd trimester, 5-pound weight gain since the last appointment, back pain 8 out of 10, shortness of breath when climbing stairs, nausea and vomiting every morning. All right. So what do I expect in the third trimester? Well, I do expect back pain because the baby is pulling on the back muscles, and they often have a problem with back pain. We teach them to do a pelvic tilt the pelvis under the baby when they're standing to help relieve some of that pain. We actually do expect shortness of breath when climbing stairs. Y'all, she's in her third trimester. Give her a break. If you walked up a flight of stairs with me, I'm sorry to say, I would be short of breath at the top of a flight of stairs. Please don't call 911 on me. That would be very embarrassing. Okay. And she's in her third trimester. She's 28 weeks gestation. She's carrying around a baby. I expect her to be short of breath when climbing stairs. I expect that at the third trimester. So B and C are expected. Now the question is, are A and D expected? So A, you have to do a little thinking on this. So in the second and third trimester, they should gain 1 pound a week. 1 pound a week is what they do in the second and third trimester. So the question is, well, when was her last appointment? Well, up until 28 weeks, they're seen once every 4 weeks, once a month or once every 4 weeks. So her last appointment should have been 4 weeks ago. 4 weeks ago, and she's gained 5 pounds in the last 4 weeks. She's supposed to gain 1 pound a month. You give them a little flexibility, okay, with that. So 5 pounds in 4 weeks is perfectly fine. Perfectly fine. There's nothing wrong with that. That's expected. So I'm not going to tell the healthcare provider about that. So do we expect nausea and vomiting in the third trimester? No, we do not. Especially this frequently. That's called hyperemesis gravidarum, which can be quite dangerous. They can become dehydrated and they can develop metabolic alkalosis. So that's a problem. So what am I going to report to the healthcare provider? I'm going to report D. And this is why it's really important to know how to answer these questions, because if you were using ABCs, and this is ABCs is about the only prioritization strategy anybody knows unless they work with us, it seems like. But if you were using ABCs, you go, C's got to be the right answer. But shortness of breath when climbing stairs certainly is expected. So you want to use the strategies we're teaching you, y'all. Hello, Clinic Review family. As you probably know, this YouTube channel is part of a bigger Clinic Review organization, and we sell NCLEX reviews online on demand, as well as do live in-person reviews. We also do tutoring, and you can learn more about that at clinicreviews.com. But we also do streaming. And so I just want to talk with you just quickly about the streaming that we offer. If you go to courses.clinicreviews.com /pages/clinic-streaming, and I will put this in the description, you can find out more about our streaming. You can start your free trial, or you can go ahead and join it for $19, and all videos are included in our 3-day trial. So what this is this is actually, you get an introduction to the Clinic Review itself, but you actually get all of our YouTube videos with no commercials. So if you go over here, you can actually pick me. You can say, oh, I want all Dr. Sharon's videos, and you can see that all of the videos that are on YouTube are also here. So you can access all these things. So if you're like, I'm not a big fan of YouTube, or I really want everything with no commercials, then you can go ahead and sign up for our streaming. And so if you sign in, I'm signed in here. So here we go. All right. So that takes me to Clinic streaming, and then I can scroll through and watch the videos. So if I go back to my dashboard, this is actually where I can then access. I can also do tutoring. May tutoring, I can do the on-demand course as well. So this is sort of our dashboard is sort of provides you with anything you pay for that you get there. Okay. So, and don't tell anyone, this is a big secret. Don't tell anybody. But I may sometimes put videos up on streaming that I don't put on YouTube. Okay. So that's a big secret though. Don't tell anybody. So I hope you have a great rest of your day. Thanks for being a part of our family. All right, 5, a nurse is completing a prenatal assessment on a woman who is 28 weeks pregnant with gestational hypertension. 28 weeks pregnant, third trimester gestational hypertension. Which findings would be reported to the primary health care provider? So again, it's a SATA question. So we're looking for the unexpected findings. She's prenatal gestational hypertension. When you see a woman who's pregnant with gestational hypertension, what should you immediately think you're going to be concerned about? You should think preeclampsia. So what are the signs and symptoms of preeclampsia? Dull headache. Yes, classic sign of preeclampsia. Weight gain of 1 pound per week. Well, that's expected, so I'm not going to report that. Blurred vision. Classic sign of preeclampsia. 1+ urine protein. Classic sign of preeclampsia, y'all. The glomerulus is a 1-cell layer, and anything that filters in the glomerulus filters through in between cells. And the things that are filtered between those cells have to be small enough to fit between the cells. So protein is normally too big to fit between the cells. So if you're getting protein in there, you're getting some glomerular damage. Fundal height of 28 centimeters. So I don't know if you'll actually be asked this question where they ask you, what do you expect fundal height to be? Because this is very specific, and I'm not sure that they will be this specific on NCLEX, but I have seen it taught before that the fundal height should be at the same height as the weeks pregnant. So even though I think that's an awfully specific marker, and I think all women are different and you can't expect all women to be exactly there, I would say, since I've been told and have heard that 28 centimeters would be appropriate for 28 weeks, just like 26 centimeters would be appropriate for 26 weeks, then I'm going to say, well, that's totally expected. So I'm cool with that. So the unexpected findings are A, C, and D. All right, last question. When the nurse is preparing the room for admission of a multigravid client at 36 weeks gestation, diagnosed with severe preeclampsia, which item is most important for the nurse to obtain? So when they give you a question like this, it doesn't have to be maternity. It could be any question. They tell you the patient has this problem, and you're getting ready to admit them. What equipment do you want at the bedside? Whether it's phrased this way, getting the room ready, or whether it just says, what equipment do you want at the bedside? It's a common question. And so you always want the equipment that's going to address the risk, whatever the risk is. So what's the risk for someone with severe preeclampsia? The risk is seizure, right? That's the risk. So what do we want? Oxytocin infusion solution doesn't do anything for preeclampsia. Disposable tongue blades, not necessary for seizure. Portable ultrasound machine doesn't do anything for seizure. Padding for the side rails, that's the seizure issue. So what can oxytocin do? Well, oxytocin starts labor. Do we want to start labor at 36 weeks? Not really. We may want it later. But I would be thinking, if we're going to take that baby early, we're going to take that baby by C-section. So I'm thinking, I don't even know if oxytocin is going to end up being there. Disposable tongue blades, not necessary for preeclampsia or seizure. It's not part of seizure precautions. Portable ultrasound machine, just might want that there, but it doesn't do anything to treat the preeclampsia or to prevent seizure. So we have to address the safety issue, the clear safety issue, which is risk for seizure, and we have to get ready for that. All right. Well, I hope this was helpful to you. If you are interested in learning more, please go to clinicreviews.com, sign up for a clinic review. We don't do private tutoring anymore. I used to do private tutoring, and I stopped doing that because I started the YouTube channel. So if that's something you're looking for, nobody at Clinic Reviews does that anymore, which is why we have this free YouTube channel for you. So we hope you have a great rest of your day. Good luck on your NCLEX. We're so glad you're part of the family.